The next presentation is Nisa Pryor. She's from the University of Utah. She's going to be speaking about stroke after aortic arch repair and is bilateral cannulation better for ACP.
Thank you. Hello, everybody. Thank you guys for having me here. It's been a great week. I've met so many awesome people. That is going to be a tough act to follow, Alicia. I don't know where you went, but great job. I did attempt to limit my caffeine intake this morning for you all because public speaking is not my forte, but as Dr. Bartos said earlier, stress inoculation here, so face your fears. I have been doing some research with my partner and classmate Cameron Hopper. He's a student with me at the University of Utah. We just graduated last week, actually. And with our advisor, Dr. Douglas Smigo. And yes, like John said, stroke after aortic arch repair is bilateral cannulation for ACP better. We have no disclosures to make. As we all know, stroke is a major complication related to aortic arch surgery, and it can be affected by multiple different factors: the patient anatomy, cannulation techniques, the type of the procedure, the urgency of the procedure, and what we do on pump. And we were trying to figure out what we wanted to do some research on, and we found that data on antegrade cerebral perfusion and its role in the occurrence of stroke is fragmentary. So we were attempting to understand how stroke location relates to ACP. And our initial hypothesis was that the occurrence of stroke will be lower in the cerebral hemisphere ipsilateral to the cannulation site compared to the contralateral hemisphere. So this was a retrospective study in which 113 consecutive aortic arch cases in which ACP was used at a university hospital setting from January 2019 to September of 2021. These patients were stroke-free at the time of surgery. And we have group 1, which was N of 24, and those were patients who suffered from a stroke postoperatively. And group 2, which is N of 89, had no stroke. Both of these groups were divided into unilateral versus bilateral cannulation for ACP. And then group 1, we looked at had CT reports and MRIs to determine the location and etiology of the stroke. This is maybe a little hard to see, but just to show you how we were attempting to determine the location of the stroke, we were just going through CT reports with our advisor and making an attempt at determining if it was left, right, or bilateral stroke. And then for the purpose of this study, I just wanted to define stroke. So in general, any new postoperative neurologic deficit, sensory or motor, mental status change, and or seizure that was confirmed with a positive CT scan. And this study does not take into consideration severity of the stroke, recovery time, or absence or presence of long-term deficits. So if the patient fully recovered from the stroke that they had postoperatively, this study does not take into account any of that. And then our patient list came from an STS database. Here's a big breakdown of our demographics, which I'll get into some details later on, but you can see we have all the typical demographic breakdowns, and then we have our CPB parameters, which I think is what we're all interested in. But we have cross-clamp time, pump time, ACP time, temperature, BSA, all of the standard stuff there. Here's an image just depicting kind of where cannulation site occurred. So we had, for our unilaterally cannulated patients, 100% of them were cannulated on the right side. And then for the bilateral cannulation, they were either cannulated in the axillary or innominate, and then the left common carotid. Our stroke rate for this patient population was 21.2%, which is quite high, and we'll talk about that a little bit later. But this is where we were surprised in that stroke location. The patients that were unilaterally cannulated on the right side, 54.55% of them had a right-sided stroke, And in the bilaterally cannulated patients, we saw 69.23% had bilateral strokes. And this is just some images depicting that breakdown there. But we were kind of surprised by this outcome. We also broke down our patient population based on priority. So we had 15.9% were elective, 25% were urgent, and 27% were emergent, and those were the stroke patients of our population. So here we just have graphs showing our stroke frequency based on those priorities. We broke our population down based on 30-day mortality. So we have an overall mortality in the group 1 patients, which was our stroke population, of 33.33%, and an overall mortality in the non-stroke patients of 9.1%. And then I have the breakdowns there of the unilateral versus bilateral mortalities in the stroke and non-stroke as well. Here's an overall breakdown of the mortality based on priority, the 30-day mortality based on priority. And as you can see, we have a higher mortality rate in the urgent and emergent patient population, which is to be expected. And then a further breakdown of the mortality based on population in group 1 and group 2, both of which we saw higher in the urgent and emergent populations, but the stroke patients were obviously higher as well. We broke our data down into disease processes, and most of them were aneurysms and dissections, obviously, of some capacity. And we also looked at the ACP flows for both groups, and we attempted to determine if they were embolic or ischemic strokes for the stroke population. That's kind of difficult, and we are still working on finding some professionals who can help us determine that a little bit more properly. But you can see there the group 1, the average flow rate for the stroke patients was 13.9 mils per kg per minute. And the group 2 average flow was 13.49. So pretty close in both of those groups. And we were happy to see that number. A quick discussion. We did have our elevated stroke rate in our population in comparison to what we had found in our outside research. 21.2% is pretty high. The potential causes for that might be due to the urgent and emergent versus elective patients. We did see a little bit of a discrepancy with the stroke rate in the urgent versus emergent population. You'd think the emergent would be higher, but I think that had to do with the classification of urgent versus emergent and just the timing. So emergent patients were defined as less than 6 hours in hospital prior to being in the OR. So maybe it was just that they were past that 6-hour threshold, but would still be considered an emergent patient. It's a university hospital. We see a lot of really sick patients. And this, like I said before, the 21.2% does not take into account recovery or lack of long-term deficits. So like I said, the stroke rate was higher in the urgent and emergent, and the mortality was also higher in urgent and emergent. Obviously, mortality was higher in group 1, the stroke population, versus group 2. We did see a significant difference in sex, pump time, cross-clamp time, and temperature between groups 1 and 2. But there was no significant difference for age, ACP time, or BSA between groups 1 and 2. Some limitations of our study that we use NIRS on all of our patients, and especially aortic arch patients, but this data was not recorded in EPIC for us. So if anything comes of this study, we would hope that it would be a petition for our university to be recording this data in EPIC, because we have it and it should be pretty simple to get done. So we've been talking with them, and hopefully that will happen quickly. And we accepted all diagnoses and all priority levels. So we are working on expanding our patient population and kind of narrowing down the groups from urgent and emergent versus elective. It's kind of hard to compare those two groups of patients with strokes and dissections or aneurysms. So And as we all know, strokes are multifactorial. When sitting down and chatting with our surgeon about the patients that we have, our stroke population, he said he could go through and name all of those patients and say, oh, this patient's recovered, this patient's doing well. So that initial, like right after, or initial post-op diagnosis is something that we want to continue looking at. So to conclude, we have rejected our primary hypothesis based on the results of this study. The stroke rate that we found did correlate highest with the hemisphere's ipsilateral to cannulation site, which is not what we had expected to see. But like we said, future studies are needed to validate these findings. And we have a few suggestions. This pre-op workup during a head CT, or before an arch case for, yes, pre-op workup for arch cases. And then a literature review on protective ACP flow rates is something else that we are looking at. What time is it? Any questions for me? Sorry, that was interesting, guys. I commend everybody who's been up here this last week because I'm terrible at this, but thank you for having me so much. It's been great.